The next speaker for the morning is Dr. Isabelle DeMesteere. She's a you all know her well, as you do, Dr. Kimmelman, but she's a gynecologist and director of the Research Laboratory on Human Reproduction at Erasmus Hospital. She earned a PhD in fertility preservation in 2005 and completed her scientific training at McGill University in Canada. She is responsible for the Oncofertility program at Erasmus Hospital and is Senior Deputy of the Fertility Preservation Special Interest Group of ESHRE and prior President of the Belgian Society of Reproductive Medicine. The title of her presentation this morning is Fertility Preservation for Low-Medium Risk Youth. Join me in welcoming Dr.
So thank you very much for this kind introduction. I'm really happy to be here. It's a great meeting, really. So my talk today will be on fertility preservation for low, medium risk young. So I have no conflict of interest regarding this presentation. And the objectives will be to define who are the patients who are considered at low, medium risk of infertility after gonadotoxic treatments, to evaluate the usefulness of marker of long-term treatment and usage damage, and to discuss the fertility preservation counseling in these low-risk patients. So as you all know, chemotherapy and radiotherapy inducing gonadal damage is why we are all here today. And it's true for male and female, but it's also can be affected, can affect the gonadal function at different level. As you can see here in male, chemotherapy can affect the spermatogonial stem cells, sperm, or in the more severe cases, Leydig cells. So that means that they have different consequences according to the doses and the total, the kind of treatment received. It can be temporary decrease of sperm quality, temporary azoospermia, permanent azoospermia, and in the more severe case, endocrine disorder. But for male, actually, most the recommendations are to cryopreserve the sperm in adults before any kind of treatment, and testicular tissue is restricted usually to high-risk patients due to the experimental procedure. But so I will focus more my talk today on female side. As you can see, it can also affect the gonadal function at different level by destroy the pool of primordial follicles, the pool of growing follicles, and use follicular activation, and also by affect the stroma cells. And here also the consequences can be different according to the type of treatment, with acute amenorrhea in most of the time during treatment, temporary or permanent decrease of the ovarian reserve, temporary amenorrhea, and POI in the more severe situation. So what does that mean in terms of fertility? If you look at this interesting study by the Childhood Cancer Survivor Study that evaluated more than 10,000 5-year survivor patients, aged less than 21 years old at the time of diagnosis, you can see that finally they don't find any difference in terms of fertility chance of conceive until 30 years old in this population. And you can see in the graph that after 30 years old, there is a decrease in the fertility potential in this cancer survival. But what they show also that the chance to conceive was correlated with some alkylating agents like busulfan or lomustine, but only finally 1% of these patients received this kind of drugs. The problem is that actually now the mean age of women at birth of the first child is around 30 years old in the majority of European countries, as you can see here, even more than 30 years old for some of the countries, and in the same in US. So we really have to think about long-term consequences of the treatment. So one of the consequences of the treatment regarding fertility is also the method of conception. Here you can see also a large study, more than 2,000 patients included, compared to sibling control. They don't find any difference in the percentage of patients who achieved at least one childbirth. But what they observe is that there is a significant lower childbirth rate in the patients with aggressive tumor. Of course, they receive usually more aggressive treatment. And they have an increased number of patients who use ART technique for achieve pregnancy. And that have been observed in male and in female. So the problem is the definition of what we call low-risk patients compared to high-risk patients. So if we go back to the Edinburgh criteria, was published in 2005 by the group of Wallace, they categorized the risk according to the type of the disease mainly and the stage. And they applied that to offer it or not ovarian tissue cryopreservation in the children. And you can see they recently published the long-term follow-up of these patients, and the prevalence of POI was indeed 24% for the group who have ovarian tissue cryopreservation with a high risk, according to treatment, and 2.5 in the low and medium risk. So it's a good classification, but actually it's based on the fact that with the increasing stage of the tumor, most of the treatment, most of the regimen are also increasing in terms of aggressivity and cumulative doses of alkylating agent received. And this is the standard treatment for lymphoma patients, and it's quite easy when you see the patients at diagnosis according to the stage of the disease and the treatment they will receive to evaluate the risk. And this is based, of course, on the fact that some of the drugs, like cyclophosphamide and procarbazine, have a very high risk of gonadotoxicity and are used usually in the high-risk patients. But now the reality of the treatment changed also, because finally the oncologists are also concerned by the overall toxicity, long-term toxicity of the treatment, and try to decrease the cumulative doses of treatment. So there is many new approach to go in this direction, like the PET-driven approach for the hematological lymphoma patients, where you have escalated dose intensity or de-escalated dose intensity treatment, meaning that they start with 2-cycle regimen of BVD, which is a very low toxicity for the gonads, and switch, for example, to a BCOP according to the response of the treatment, or continue with ABVD. And in the de-escalated dose intensity, you start with the most aggressive treatment and then decrease according to the response to the treatment. That means that you need to have a fertility counseling adapted to this kind of strategy, and maybe rediscuss the fertility preservation option after the first 2 cycles, at least for the escalated dose intensity treatment. Because finally, when you see the patients at diagnosis, you don't know really at which kind of category of risk they will belong. And for the de-escalated dose intensity, you start with a high doses regimen, but finally the risk can be very different according to the second round of chemotherapy. As you can see here in the standard group, that there is patients who receive full doses of BCOP, and the study group were those who switch with a lower gonadotoxic regimen. And finally, in this study, we follow the patients for up to 5 years, and we observe a difference in terms of POI risk for 46% in the standard group versus 14% in the study group. So for the counseling, it's very different, of course, if you talk about the risk of POI. And same for the treatment, hematological stem cell transplantation. We used to say that, okay, you have more than 80% risk of POI when you have hematological stem cell transplantation. But now they introduce also reduced risk intensity conditioning regimen where more than 50% of the adult patients restore their menstruation after treatment. So again, it's a high-risk treatment, but the counseling should be adapted. What say the guideline regarding the threshold, how to classify the patients low and medium risk? Actually, we try to review all the treatments in this guideline by the Pan-Care Life Consortium. And we finally decided for a cutoff doses of cumulative doses of cyclophosphamide of 6,000 and 8,000 milligrams per meter square. And this is based on the fact that the fertility impairment is significantly impaired when you reach these doses. But we also highlighted in this guideline that there is, for many drugs, no really evidence about the toxicity. And I'm happy to learn that the ESMO have recently published a statement to encourage and to systematically assess the fertility in all the oncological trials. So what we can use as a marker to define the low and medium risk patients. So as you know, ovarian reserve, the best marker is IMH. And IMH is secreted by the small growing follicle. So during chemotherapy, you have a huge decrease in the IMH level. But then, as the follicle grows again after treatment, you have a restoration of the IMH level. So it can be used to identify the damaging effect in adults. But in this review, we also identified 24 studies that included pediatric patients. So can we use this marker in this population? So actually, if you look at the IMH recovery rate, it's correlated with the previous IMH level. As you can see in this, the first graph, so in red is the patients who have a low IMH level, and in blue, high IMH level at diagnosis, and of course it's correlated with the chemotherapy. But the problem is the children that, as you know, the IMH level increased during all the childhood period and adolescence until to reach a plateau on around 20 to 25 years. And actually, if you look at this graph, 12% of the children have an IMH below the cutoff value of 8 picomole per ml, so very low IMH level, despite they have a normal ovarian reserve. So it's difficult to use the marker of IMH at diagnosis to evaluate the risk for these patients. And there is another study showing that also the IMH level is decreased at diagnosis in many patients, in many children, due probably to the disease itself. But anyway, this marker have been used in pediatric patients in 2012. The group of Wallace also showed that it's useful to differentiate the high-risk and medium-low-risk patients. As you can see here, the low-medium-risk patients, they have a recovery of IMH after treatment, while the high-risk patient did not. So in the population of adults that have been treated for cancer between 2 and 17 years old, 38% of the survivors have a low IMH level, and this is correlated with the doses of cyclophosphamide received, equivalent doses, of course, the pelvic irradiation, the age at diagnosis. This is important to know that the prepubertal patients have a better recovery than the postpubertal patients. And of course, if you evaluate this in adult population, as for general population, the use of contraceptive pill and the age, of course, affected the dosage. So is it correlated with fertility? Actually, here you can see this large study also in hematological patients who have been diagnosed at a mean age of 13, and the median age time since diagnosis was 16 years, so a long-term follow-up. So they evaluated IMH and fertility. What they show that finally in this population, only one patient reported POI, but 30% of the survivors have a high FSH level, and in other studies it's up to 50%. The IMH level was below P10 in 26 patients out of 84. And of course, there is a high risk of IMH, a low IMH level in this population compared to the control. But finally, 90% of the women who ever attempt to become pregnant succeed in this population. And the median age at the first pregnancy was around 29 for the lymphoma patients. So a lot of patients with a low IMH level, with a high FSH level, but finally they succeed to conceive. So we addressed this question in our population a few years ago, where we evaluated actually all the patients who had been diagnosed with, all the patients between 3 and 16 years old, diagnosis with cancer, and we classified them according to the treatment with high risk and low medium risk. And the mean age at diagnosis was 8, and we contact the patients for hormonal evaluation at around 14 years old. And what we observe is that finally, for the high-risk patients, half of them reported POI at the time of the hormonal assessment. And all of them have been counseling for fertility preservation. For the low-medium risk, none of them have reported POI, and none of them have ovarian tissue cryopreserved. But if we look at the right graph here, you can see that for the low-medium risk, 4 of them have value out of the normal level for FSH or IMH. So what will be the consequence, long-term consequence for these 4 patients to not have performed fertility preservation? And so we decided to address this question in a more large multicentric prospective trial, where we evaluated systematically the IMH level in all the patients between 3 and 14 years old who receive chemotherapy. And so we have here 3 groups of patients: those who have a low risk, below 40,000 milligrams per meter square equivalent doses of cyclophosphamide, medium risk between 4,000 and 8,000, and high risk above 8,000. And here it's just the interim analysis we just performed last week, just for the consortium actually. I think I will share that with you because there is some interesting point to discuss based on this data. So most of the patients were prepubertal at diagnosis. You can see there is some difference in the indication, but it's normal. Interestingly, only half of the patients who have high risk actually perform ovarian tissue cryopreservation, and 2 of them receive only GnRH analogs. But we have also patients who perform ovarian tissue cryopreservation in the low-risk population and in the medium-risk population. So there is probably something to do here to better counseling these patients. What we can see in this interim analysis regarding the level of IMH after at least 1 year of follow-up, and for some of them we have 4 years of follow-up already. So it is clear that for the low-risk group, there is a slight decrease of the IMH level during the treatment and after the treatment, but finally, they completely restore their IMH level. For the medium risk, the decrease of IMH level is more important during and after treatment, but they restore IMH level, but not totally at the initial level. And for the high risk, they maintain a low IMH level after treatment. There is no restoration. For FSH level, same observation, complete restoration in the low-risk group. The medium risk, there is no POI reported, but finally the FSH level was slightly higher after treatment than before treatment, even after a few years. And for the high-risk group, already 41% of the patients was diagnosed with POI. So what we can say from this study and from the literature is that it's clear that fertility preservation should be offered to all children and AYA with a high risk. And I think the cutoff of 8,000 total dose cyclophosphamide is quite a good threshold. There is no evidence that fertility preservation will benefit from the low, medium risk prepubertal children. There is no evidence that fertility preservation will benefit for low-risk AYA patients, and there is limited evidence that fertility will benefit from medium-risk AYA patients, based maybe on the long-term effect on the ovarian function and the high risk of using ART to conceive. So I think for this patient, the most important is to recommend the post-treatment fertility preservation counseling and follow them and maybe perform fertility preservation later according to the family project. So in conclusion, I will say that all young patients who receive gonadotoxic treatment should be informed about the effect of treatment on the ovarian function, irrespective to the risk. There is no evidence of reduction of future chance of pregnancy in low-medium risk young, but more long-term prospective trials are required. Counseling should be adapted according to the treatment strategy and include information that really help the patients to make informed decisions regarding fertility preservation. And Oncofertility counseling is actually a continuous process, including counseling during and after treatment. So thank you very much for your attention.
All right, we have time for questions. Looks like we have several. Yes, Dr. Moravec.
Thank you, Isabelle. I'm losing my voice, sorry, so much for your wonderful talk. I am curious, and I loved seeing your unpublished data, and I hope to see it published soon, but I'm curious if you have enough participants in there to divide any further by AMH before treatment. I sometimes worry about, even for the medium risk patients who are already coming in with an elevated FSH or a decreased AMH, if maybe that is someone I should be intervening in.
Yeah, this is planned. Actually, we did not complete the recruitment process in this study. So just an interim analysis, but I just want to already share the previous data, because I think it's already clear that there is clear difference between the three groups. But it's planned in the further analysis, yes.
Lillian Meacham, Atlanta. That was a beautiful presentation. I really love the way you pulled it all together. And I think it really gives us pause about when to take out ovaries, et cetera. So I think it's so important. The other thing I'd like to know is, I liked your CED cut points, but they really didn't stratify by, I think the prepubertal girls maybe can even tolerate more before we bump them into the high-risk category. And then I'll just sort of echo what Jen Levine has said before, too, and that is, if an ovary is taken out for something less than high risk, and then the remaining ovary is now exposed to chemotherapy, how does that impact? So maybe really pausing and I'm supporting your point to be sure that we're looking at high-risk girls. Thank you for your work.
Yes, thank you very much. Yes, it was really what we would like to address in this study. So really to see if there is, well, what is the balance risk-benefit for these young patients who have ovarian tissue cryopreservation, and also maybe to change a little bit the way of counseling and make something more continuous with time and post-treatment oocyte cryopreservation maybe later in life if they want to conceive later. Yeah, because our concerns was, of course, not to do it if it's not necessary, but maybe not to avoid a fertility issue in patients who did not perform fertility preservation. That yeah, this is
Great presentation. Thank you.
Thank you.
Dr. Kimmelman?
Thank you so much for this amazing presentation. I have a practical question. When I do the follow-up of the children that had cancer, like survivors after 5 years of survivorship, and how do you manage when you have, like, for example, a 15-year-old girl, adolescent, that has a very low ovarian reserve? I mean, she has her periods every month, but she has a, like, 0.2 or 0.5 AMH. I mean, we don't know, we can't predict what's going to happen. So sometimes you offer fertility preservation when there's a very low ovarian reserve, knowing that she will have very low number of oocytes. How do you manage that with them?
But actually, in children, we perform IMH measurement at diagnosis, but it's not an indication for us to perform or not ovarian tissue cryopreservation, because in many situation we have a low IMH level, and finally the follicular density was very good in the tissue. So we really think differently than in adults, and the IMH level was more an indicator for us for future, maybe understanding better what's happening in this patient and how we can use this marker in the future. But it's not a limited factor for doing ovarian tissue cryopreservation in high-risk patients.
Astrid?
Yeah, thank you. Well, it's excellent talk.
Thank you.
So I have kind of 2 to 3 questions. One is, you said that the AMH level was within 1 year was still low, but then especially in the medium risk, then it was starting rising, right? So first, would you then recommend to just do it later than 1 year to really have, you know, something? And then the other thing is, would you then wait after puberty and then reevaluate? Because the consequence is like you will not freeze tissue 1 year later, right? I mean, if you have a prepubertal and then you say, okay, AMH level is rising, but still on a lower level, you would not go back and freeze tissue then. No. Exactly. And then, so the other thing is, I think more from practical point of view, I think what is always a big challenge is to know what will the future bring concerning the chemotherapy. Because what we all struggle with, I think, is that you try to get this answer from the oncologist. Said, okay, what is the worst case scenario of treatment? And this is something that most of the cases they cannot tell you. So I think the risk is always to undertreat or to overtreat. So especially in the lymphoma patients, when you cannot predict how they will react to the first low gonotoxic treatment, and then suddenly you end up in the high-risk group. So how do you deal with that?
Yes, so for the time point of the study, we have actually a time point at the end of the treatment, but also a time point at 1 year from screening and 1 year from follow-up. And we perform this double time point at 1 year because there is a lot of leukemia patients who receive a long-term treatment for many times, so we want to see if there is a restoration in this patient. So it's why it's a little biased. But so the time point for recovery is 1 year post follow-up. But here there is 1 year post screening also. It's why.
Okay.
For the patients who are at the low risk and then shift with a high risk, we offer ovarian tissue cryopreservation before starting the high-risk treatment. And actually, in the young population, there is no impact on the outcome of the ovarian tissue transplantation if they have a low-risk treatment before. So that has been quite well demonstrated. So I think we can really wait until really know what kind of treatment they will receive.
Kenny.
Congratulations, Isabelle. It's a beautiful paper. I think we are all looking forward to read the final paper published. There are some countries that already have guidelines for fertility preservation for children. In Sweden, we have already guidelines, and they are going to be reviewed next year. So your paper is going to be an impact. It's going to make an impact in the current guidelines. But from the guidelines, I think it's very important just to point out that in programs for fertility preservation for children, the best partner we can have is the pediatrician endocrinologist, because they are going to follow the children during the whole childhood until they become adults. And if they are alert and they discover that there is hormonal secretion and this girl maybe has some estradiol production, and so they can send the patients quick to us, and we can provide an opportunity to do fertility preservation, maybe if it was not possible before the treatment. In our national guidelines currently, we have established that all patients that become adults at the age of 18, they have to be sent to a reproductive medicine specialist to have this discussion to see if there is an opportunity then.
Yes, I agree. Yes, it's a good point. And actually, yes, of course, the pediatric oncologists are really partner in this decision. But it was addressed yesterday afternoon by cancer survivors. The parents' decision is very important in these three children, and they have to understand. And it's even more difficult in this population because they have to decide for their children. It's why I think we need to provide as much as we can, good information about the real risk. Yes.
Thank you. Jen?
Jen Levine from
Thank you.
DC. Thank you so much. That was such an excellent, comprehensive talk. And I think the conundrum that you raise about the Hodgkin lymphoma patients specifically is a real one, where your risk can change midway through. And I think in my experience in New York, especially because a lot of them are young adults, that most of those patients can be started on steroids and actually maybe have the chance to do oocyte cryopreservation, even if their upfront therapy is going to be ABVD, because you don't know what's going to happen down the road. And especially for the young adults, where really their autonomy about decision-making is so, critical, that, even if it's with that lack of clarity, that many might want to pursue that. And I do think there are medical interventions on the oncology side that can support that. So I think that's such a critical point, and it kind of is what drives the issue with the boys too, for the recommendations. Like, your risk can change. So thank you for...
Yes, thank you very much for this comment, because yes, it's clear that here I address more specifically the population of children and adolescents. That is more difficult to offer them oocyte cryopreservation. In prepubertal children, certainly not. But you're right, in adults, it's why I say that all the patients should be counseling, and it's finally a patient decision-making. But in adult, of course, patients who are stressed for the fertility, even she receive ABVD, we can reassuring, but if she want to cryopreserve the eggs before, it's okay.
Thank you for your questions. Thank you so much, Dr. DeMesteere.